A procedure considered low risk at 50 can become lethal at 80. In certain operations, mortality rises from under 5% to over 40%. This video is for educational purposes only and is not medical advice. Always consult your doctor. There are surgeries that no older adult should agree to without serious informed deliberation, and we will examine 5 of the most consequential. But the reason these procedures turn deadly has less to do with the surgery itself and more to do with a condition that affects nearly 40% of adults over 75, one most patients have never been tested for. Frailty is a clinical term that describes a measurable decline in the body's ability to recover from illness, injury, or surgery. In older adults, we often see that frailty is not simply about age or the presence of medical conditions, but about a loss of physiological reserve, the body's backup systems that help manage stress and heal after setbacks. Studies show that after age 75, between 20 and 30% of community-dwelling adults meet accepted criteria for frailty. This means that even when living independently, about 1 in 4 to 1 in 3 older adults has a significant reduction in strength, endurance, and resilience. Frailty is assessed using standardized tools such as the Fried Frailty Phenotype and the Clinical Frailty Scale. These instruments look at factors like unintentional weight loss, weakness, slow walking speed, low physical activity, and self-reported exhaustion. A person who is considered frail may have difficulty climbing stairs, recovering from minor infections, or bouncing back after a fall. The difference between a robust and a frail older adult is not always visible, but it becomes clear when the body is placed under the stress of a major operation. The prevalence of frailty rises sharply with age. In the cardiovascular health study, only about 7% of adults aged 65 to 74 were frail, but this increased to nearly 20% in those over 80. The National Health and Aging Trends study found that 22% of adults aged 75 to 79 and 28% of those 80 and older were frail when using the Clinical Frailty Scale. Systematic reviews confirm that frailty affects roughly a quarter to a third of seniors in developed countries, with the highest rates seen among those living in nursing homes or receiving hospital care. Clinically, frailty signals a drop in the body's ability to withstand surgical stress. After age 60 or 65, the capacity for recovery declines and the risk of complications rises, even in the absence of major chronic illness. This is why in older adults we pay close attention to frailty when discussing the risks and benefits of surgery. It is not just a matter of age, but of how much reserve the body has left to handle the demands of healing. Next, we will look at how frailty affects specific organs and why this matters for surgical outcomes. This video is for educational purposes only and is not medical advice. Always consult your doctor. As the body ages, the ability of individual organs to withstand surgical stress declines in ways that are both subtle and profound. In older adults, the kidneys become especially vulnerable. With each passing decade, glomerular filtration rate drops, and by age 80, renal clearance may be half of what it was at age 40. This decline means that medications and anesthesia agents linger longer in the bloodstream, raising the risk of toxicity and post-operative complications. Data from large surgical cohorts show that the rate of acute kidney injury, AKY, rises from about 5% in younger patients to 12% in those over 80. Even a mild episode of AKY can double the risk of long-term loss of kidney function or a prolonged hospital stay. The immune system also undergoes significant changes. Immunosenescence, the gradual weakening of immune defenses, makes it harder for older adults to fight off infection after surgery. Studies show a twofold increase in surgical site infection and pneumonia rates among patients over 75 compared to those under 65. Delayed wound healing and a slower response to antibiotics can turn a minor complication into a life-threatening event. Chronic conditions such as diabetes and vascular disease, common in this age group, further erode the body's ability to recover. The brain is another organ at heightened risk. After major surgery, older adults are more likely to experience post-operative cognitive dysfunction, a term that describes a measurable decline in memory, attention, and executive function. This can range from mild confusion to persistent difficulty with daily tasks. The incidence of cognitive dysfunction rises with age and frailty and is seen in up to 30% of patients over 80 following major procedures. These changes can persist for weeks or months, complicating rehabilitation and increasing the likelihood of discharge to a nursing facility rather than home. Taken together, these organ-level vulnerabilities help explain why even routine operations can have outsized consequences in seniors. The body's backup systems are less able to compensate for surgical stress, making complications more likely and recovery less predictable. Understanding these risks is essential before considering any high-stakes procedure. In the next sections, we will examine how these vulnerabilities translate into real-world outcomes for specific surgeries in older adults. This video is for educational purposes only and is not medical advice. Always consult your doctor. Emergency abdominal surgery in older adults, such as a laparotomy for bowel obstruction or perforation, places the body under a level of stress that few seniors can withstand without consequence. When the call comes in the middle of the night, there is rarely time to optimize chronic conditions or address underlying frailty. In national databases, the 30-day mortality rate after emergency laparotomy is reported between 12 and 18%. For patients aged 65 to 74, for those over 85, the risk rises above 40%. Major complications, including sepsis and respiratory failure, affect more than half of the oldest patients. These numbers reflect the reality that once physiologic reserve has dwindled, the body may not survive a sudden, overwhelming insult, even if the operation itself is technically successful. Survivors of emergency abdominal surgery face a high likelihood of prolonged mechanical ventilation, new or worsening cognitive impairment, and a transition to institutional care. Stroke and delirium are common in the days after surgery, with up to 1 in 3 older patients experiencing some form of acute brain dysfunction. For families, the aftermath can mean weeks or months in intensive care, followed by rehabilitation or long-term nursing placement. Planned open-heart surgery, such as coronary artery bypass grafting or valve replacement, brings a different but equally sobering risk profile. Even with preoperative assessment and careful preparation, the physiologic strain of cardiopulmonary bypass and anesthesia can overwhelm the aged heart and brain. In national cohort studies, 30-day mortality for cardiac surgery ranges from 10 to 14% in the 65 to 74 age group, rising to 24% in those aged 75 to 84, and as high as 38% in patients over 85. Postoperative stroke, cognitive decline, and prolonged delirium are more likely in older adults, particularly those with pre-existing frailty or mild cognitive impairment. In both emergency and planned high-risk operations, the difference between survival and severe decline often comes down to the body's remaining reserve. The gradient of risk is steep, and the likelihood of returning to independent living after these procedures drops sharply with each passing decade. For some, the operation may extend life or relieve suffering. For others, it can mean a loss of function or independence that cannot be regained. This video is for educational purposes only and is not medical advice. Always consult your doctor. A broken hip in an older adult is rarely just a bone injury. In clinical practice, hip fracture repair is often the moment when the question of independence comes sharply into focus. Each year, more than 300,000 Americans over the age of 65 are hospitalized for a hip fracture. Surgery is almost always required, but the outcome is far from guaranteed. National data show a 30-day mortality rate of 6 to 8% for patients aged 65 to 74, rising to 20 to 25% for those over 85. Yet the numbers only tell part of the story. Recovery is slow and complications are common. Delirium, pneumonia, and blood clots affect up to 1 in 3 patients. In the months after surgery, fewer than half of older adults regain their previous level of mobility. For many, the operation marks a permanent loss of independence. Studies report that about 40% of seniors who were living at home before their fracture are discharged to a nursing facility. 1 year later, only about half will have returned home. There is evidence that outcomes improve when geriatricians and orthopedic surgeons co-manage these patients. Multidisciplinary care can reduce 30-day mortality by nearly a third, dropping the risk by about 2% in absolute terms. This may seem small, but across hundreds of thousands of cases, it represents thousands of lives. Still, even with the best care, the risk of death and disability remains high. Complex spinal fusion is another operation where the risks extend far beyond the operating room. In older adults, this surgery is often performed to relieve severe back pain or nerve compression. However, the procedure is long, often lasting several hours, and requires general anesthesia and significant blood loss. The 30-day mortality for spinal fusion ranges from 5% in those aged 65 to 74 up to 22% for patients over 85. Severe complications such as infection, nerve injury, or respiratory failure are not uncommon. Perhaps most concerning is the long-term impact on function. Only about 45% of seniors regain their baseline level of mobility and independence 1 year after a complex spinal fusion. For the rest, persistent pain, weakness, or new disability may become part of daily life. In these cases, surgery does not just threaten survival, it can take away the ability to walk, to dress, or to live alone. In both hip fracture repair and spinal fusion, the true risk is not just in the numbers, it is in what may be lost. The capacity to remain independent, to recover, and to keep living life on one's own terms. This video is for educational purposes only and is not medical advice. Always consult your doctor. Pancreatic duodenectomy, often called the Whipple procedure, is considered one of the most demanding operations in surgical oncology. In older adults, the physiologic challenge of this surgery is profound. The operation involves removing the head of the pancreas, part of the small intestine, the gallbladder, and the bile duct, then reconstructing the digestive tract. For patients in their 70s or 80s, the stress of this procedure can overwhelm even a previously healthy body. This video is for educational purposes only and is not medical advice. Always consult your doctor. National registry data show that for adults over 70, the 30-day mortality after pancreatic duodenectomy ranges from 8 to 12%. For those over 80, the risk climbs to more than 25%, meaning 1 in 4 patients in this age group will not survive the first month after surgery. Major complications are even more common. In seniors, more than 40% experience a severe post-operative event, such as an anastomotic leak, intra-abdominal infection, or sepsis. These complications frequently require a return to the operating room, prolonged stays in intensive care, and weeks of intravenous antibiotics or nutritional support. Consider the experience of an 81-year-old man with newly diagnosed pancreatic cancer. He was living independently and managing his chronic conditions before surgery. After the Whipple procedure, he developed a pancreatic leak that led to overwhelming infection. Despite aggressive treatment, he spent 28 days in the hospital, most of it in the ICU, and was ultimately discharged to a skilled nursing facility. He never regained his previous level of function. Clinically, the intention behind pancreatic duodenectomy is curative. Yet, in older adults, the chance of cure must be weighed against the very real possibility of life-threatening complications. Even in high-volume centers, the risk remains substantial. The uncertainty of benefit is magnified by the fact that in many cases, cancer may already have spread microscopically, limiting the long-term survival advantage of surgery. For patients and families, the decision is rarely straightforward. It requires a clear understanding of both the potential for cure and the significant burden of harm. In these situations, it is essential to ask not only whether surgery is technically possible, but whether it aligns with the patient's goals and tolerance for risk. For some, The possibility of extra months or years of life outweighs the dangers. For others, the likelihood of severe complications, loss of independence, or prolonged recovery may tip the balance toward conservative treatment or supportive care. The numbers alone cannot make the decision, but they provide a sobering context for what is at stake. This video is for educational purposes only and is not medical advice. Always consult your doctor. In older adults, we often see that risk can be measured quickly and objectively long before a decision about surgery is made. Two of the most practical tools are the clinical frailty scale, called CFS, and the gait speed test. The scale assigns a score from 1 to 9 based on a person's function and medical complexity. A score of 5 or higher signals moderate frailty and predicts a 12 to 30% chance of death within 30 days after major surgery. Gait speed is even simpler. Walking 5 meters at less than 0.8 meters per second doubles the risk of death and triples the risk of delirium regardless of other health problems. Both screens take less than 2 minutes to perform and can be done in any clinic. Another factor that consistently changes outcomes is hospital and surgeon volume. Studies show that having surgery at a high-volume center, defined as at least 50 cases per year, reduces the risk of death by 15 to 30% compared to low-volume hospitals. For older adults facing high-risk operations, asking for a frailty assessment and choosing a team with substantial experience can make a measurable difference in survival. These numbers do not replace personal judgment, but they provide a starting point for asking the right questions before agreeing to surgery. This video is for educational purposes only and is not medical advice. Always consult your doctor. In older adults, we often see that preparation before surgery can make a measurable difference in outcomes. Prehabilitation, a focused program of exercise, nutrition, and sometimes medication review, has been shown to reduce post-operative complications by 15 to 25%, even in frail patients. For those considering surgery, taking 3 to 6 weeks to build strength and endurance can shift the odds toward a safer recovery. Before agreeing to any high-risk procedure, there are key questions that every patient and family should bring to the surgical team. What are the alternatives to surgery, including medical management or less invasive procedures? How will frailty and other chronic conditions affect the risk of complications or loss of independence? What is the expected recovery time, and what kind of rehabilitation or support will be needed afterward? Is this operation being performed at a high-volume center with experience in older adults, and has my frailty been formally assessed? Finally, what are the chances that surgery will help me reach my personal goals for function and quality of life? Asking these questions and considering a period of prehabilitation can help ensure that the decision to proceed with surgery is as informed and individualized as possible. This video is for educational purposes only and is not medical advice. Always consult your doctor. In older adults, we often see that even routine procedures can carry unpredictable risks. Studies show that frailty and age-related changes sharply increase complication rates after surgery. Clinically, the best outcome depends on individualized assessment and clear discussion. Every decision deserves careful thought. The risks you weigh today shape the quality of life tomorrow.